Good morning, everybody. We'd like to welcome you to the February 22nd, 2024 PACCARB public meeting. We have an exciting agenda today, and we will be moving forward with starting on that here briefly. But at this point, I would like to take a few minutes to, number one, thank our PACCARB administrative team for all of the work they've done to set up this schedule, bring these speakers in, and prepare for today's presentations. The PACCARB committee is largely in person in DC, and we welcome those of you online and our online speakers for today's panels. We have three important panels that we're going to talk about today. The first one's going to start with an overview of education, knowledge, and behavior, followed by a panel on prevention of AMR infections and access to treatments, and then a final panel focused on data sharing and networks. These panels have been designed with speakers that will help inform PACCARB and our working group in our efforts right now to develop a report to Secretary Becerra focused on recommendations on how the United States can lead in the area of global AMR recognition and response. These speakers will inform our thoughts and our work on those panel topics and will certainly be important as we fill out the components of our recommendations. I encourage the PACCARB panel or the PACCARB Council in general to ask good questions, be thinking about how these speakers can help inform questions we've discussed in working group or other meetings on areas that we have additional or need additional information on regarding our thoughts around the report, and certainly to take advantage of the expertise we have with us today. With that, I'd like to turn the mic over to Dr. Jason Newland for a couple comments.
Thanks, Paul. Want to thank all the council members for being here today for this great session that we're going to have. Appreciate our staff, and I appreciate the speakers who've taken the time. I'll just make one comment just to set and think, antimicrobial resistance impacts everybody. And it is bigger than just an infection, I would say. Recent paper published in JAMA and giving mass use of azithromycin to children in Burkina Faso showed that potentially there's a mortality benefit, and there's another Mordor trial that showed it. But why? Why do we need to use azithromycin to prevent mortality in children? Why does that have to be there? What other things can we do as to make the world better? I think antimicrobial resistance is just one of the many factors, and I hope that we can think big as we prepare for this report to give to Secretary Becerra and for the United Nations General Assembly in the fall. I'm excited. I can't wait to have more discussions. And with that, I'll turn it over to our wonderful leader, Jomana.
Thank you, Jason, and good morning to everyone. We're excited to have our council members here. This is our first hybrid event where we have all of our presenters joining us virtually, but the council only is here in person. All members of the general public are welcome to join virtually online on the HHS.gov/live1 link, and we're happy to be discussing this so that we can hopefully have a report, as mentioned by my chairs, for deliberation and vote at our next public meeting come May. So on to the formalities. And again, good morning and welcome to what is now the 25th meeting of the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria. As mentioned, I am the designated federal officer for this advisory council. And I'd like to thank all of our presenters, attendees, stakeholders for joining us today, including those who provided public comment. All public comments submitted to the CARB, C-A-R-B, at HHS.gov mailbox have been provided to the council members. A little bit about the council, as you all know, we were initially established via executive order in 2014, and then in 2019, we were codified into legislation through the Pandemic and All Hazards Preparedness and Advancing Innovation Act, and this formally reestablished under this statute as of September 2nd, 2020. The goal of this advisory council is to give the Secretary of Health and Human Services advice and recommendations to improve the programs and policies related to antibiotic resistance that would contribute to the overall health of our country and globally. To accomplish that mission, the Advisory Council strives to address the issues related to antibiotic resistance through a One Health approach, which is evident in all of our proceedings and products and membership. Before we start, there are a few things that all of you should know. This meeting is being recorded and will be available on our website, hhs.gov/PACCARB. Second, this Advisory Council is governed by the Federal Advisory Committee Act, also known as FACA, where the majority of the work of this Advisory Council, including information gathering, drafting of reports, and the development of recommendations, is performed by designated working groups, who in turn report to the full Council for deliberation and final vote, as will take place in May. Regarding the conflict of interest rules, all 15 voting members of this council are considered special government employees and are subject to conflict of interest laws and regulations. The 12 regular government employee members representing different agencies and departments on this council have also been vetted for any conflicts of interest. Lastly, I'd like to thank the amazing PACCARB team, Ms. Sarah McClellan, Ms. Haley Krem, Dr. Zena Francis, Ms. Lauren Plain, Dr. Mark Kazmierczyk, and Ms. Jennifer Adana for their efforts to support the council and plan for this meeting. I will now go through a roll call for all of our council members. Please let us know if you are present by stating here. For our alternate representative members, please identify yourself and provide the name of the principal you are representing today. All right, we'll start with our chair, Dr. Paul Plummer.
Present.
Dr. Jason Newland.
Here.
Dr. Stephanie Black. Here. Dr. Claire Burbick, are you with us virtually?
Yes, I am. Thank you.
Thank you. Dr. Virginia Fate. Here. Dr. Susan Wong.
Here.
Dr. Jenny Kwan.
Here.
Dr. Brian Lubers.
Here.
Dr. Lynn Marks.
Here.
Mr. Armando Nahum.
Here.
Dr. Payal Patel. Here. Dr. Robin Patel, virtually.
Here.
Dr. Joni Sheftel.
Here.
Dr. Julie Simzak.
Here.
And Dr. Tom Whittam.
Here.
Excellent. Thank you. Moving on to our liaisons, representing the American Association of Extension Veterinarians, Dr. Carla Houston. Here. Representing the Bill and Melinda Gates Foundation, Dr. Padmanee Srikantia.
Here.
Representing the Biotechnology Innovation Organization, BIO, Ms. Emily Wheeler.
Here.
Representing EpiX Analytics, Dr. Francisco Zagmet.
Here.
Representing the Minor Crop Farmer Alliance, Dr. Jim Adaskovich. Representing the National Institute for Animal Agriculture, Dr. Lucas Pantaleon.
Here.
Representing the Society of Infectious Disease Pharmacists, Dr. Libby Dodds Ashley.
Here.
And lastly, representing Wellcome Trust, Dr. Tim Jinks.
Here.
Thank you. On to our RGEs, our regular government employees. For USDA, Dr. Jeff Silverstein.
Roxanne Matroni here for Dr. Silverstein.
Okay, thank you for joining us, Roxanne. Dr. Sarah Tomlinson.
Dr. Chelsea Shively here for Dr. Sarah Tomlinson. She is also joining us online as available.
Thank you. Dr. Kiss Robertson Hale.
Present.
Thank you. On for DOD, Dr. Paige Waterman.
Here.
All right, on to our HHS colleagues. For the Administration for Strategic Preparedness and Response, ASPR.
Mark Albrecht, here for ASPR.
Thank you, Mark. For AHRQ, Agency for Research, Healthcare and Quality.
Melissa Miller here.
Thank you. For the CDC.
Michael Gregg.
Thank you. For CMS. Anyone online for CMS? Okay. For the National Institutes of Health.
Kyungmoon, I'm here for Dennis Dixon.
Thank you. For the Office of Global Affairs.
Patrick McDermott here.
Thank you. For FDA.
Bill Flynn, here.
All right. And lastly, for EPA.
Jay Garland, here.
Thank you so much. All right. Thanks to everyone for attending this important meeting, and just a few more housekeeping items to remember. All council members who wish to ask a question or have a comment to use their name card by popping it up vertically or raise your hand. The moderator for each Q&A session will call on you. For those of you in virtual land, please be sure to raise your hand virtually using the little button on Zoom. And once you've been called on, please remember to unmute the microphone at your seat or virtually before speaking, and then mute yourself following your comment or question. And now I'd like to introduce our patient story. Is our patient online, folks?
Yeah.
All right, excellent. And I now have the pleasure of introducing Dr. Felix Lau, an ICU pediatrician in Jakarta, Indonesia. Dr. Lau is a member of the World Health Organization, AMR Survivors Task Force, Members of the WHO Survivors Task Force aim to help shape the AMR narrative globally and influence policies that affect AMR. They also contribute to improvements in AMR messaging so that the human face of AMR is presented alongside messages that increase awareness of AMR. I now ask you to please turn your attention to Dr. Lau, and thank you so much for joining us so late.
So thank you all. Thank you to the PACCARB committee for inviting me to present my own story as a pediatrician and also as a pediatrician as well. So I am one of the members of the WHO AMR Survival Task Force. We are 12 members, so I am one of them. So I think I can start with my presentations. But before I'm first I would like to apologize if I cannot speak English fluently, but I try my best. So I hope all of you can understand what I taught in this meeting. So next slide, please. So as a background, I live in Indonesia. As you might know that Indonesia is a very large country. I work now in the Jakarta, capital city of Indonesia. But before working in Jakarta, I also work in west part of the Indonesia called Sumatra Island, and also work in the central part of Indonesia called Borneo Island, and the east part of the Indonesia called Celebes Island. So this wide geographic area means that the host systems is vary from all of the cities. So I cannot compare what I have in capital city than what I did in another remote area in those islands. So next slide, please. So as a caregiver, after 7 years marriage, my wife delivered a son, our son, after 7 year marriage. It was a heavy moment for sure, but start after birth, my son has a diarrhea, and then he also kept vomiting and also have mild fever. As a pediatrician, I thought that my son maybe have a gastroesophageal reflux. So I think it will be normal for a couple of days or couple of weeks. But after 2 weeks, my son did not gain his body weight adequately. He was born with 2,300 grams, and then after 2 weeks, his body weight still the same, 2,300 grams. So at the time I was very worried, and then at the time also my son also had a dehydration. So I took to the hospital at the time. Next slide, please. Next slide, please. Next. And then the doctor in charge at the hospital performed some laboratory findings. Some of the laboratory showed that my son had a high platelet count, slightly elevated CRP, and also found mucus positive on the stool. The doctor in charge diagnosed my son for suffering neonatal sepsis. So my son was prescribed many kinds of the antibiotics from the first line, second line until the third line of antibiotics, but the symptoms keep persisting. So I also has a second opinion to one of the professor. The professor said maybe my son had a severe cow's milk protein allergy. So the professor suggests me to give my son with Neocate, as we know that it is the brand name of the amino acid formula milk. But still, my son kept diarrhea and kept vomiting. And then the second visit, the professor changed the milk with the pure amino, which is also the extensive hydrolyzed milk and also the amino acid. But still there is no improvement. And then because of the severe dehydrations, I took my child to the hospital again. And then at the end, I took my hospital to one of the big hospital in Indonesia. Next slide, please. And then the doctor in charge in the reference hospital performed stool culture and it showed Klebsiella pneumonia and also performed serial blood culture. At first, and the second of the blood culture showed no growth, so the blood culture was sterile. But unfortunately, on the third blood culture later on, the blood culture showed multi-drug resistant Staphylococcus. So I think at that time my son was suffer from hospital-acquired infections because of the recurrent admissions and prolonged admission in the hospital. Next slide. Next slide, please. Yeah, these are some of the antibiotics that was prescribed to my son. At first, at the first line, he was given ampicillin, sulbactam, and gentamicin, and the second meropenem, and the third antibiotic was teicoplanin. Teicoplanin was prescribed after the doctor in charge found multi-drug resistant of Staphylococcus in my son's blood. But unfortunately, I cannot find the teicoplanin in my place. I also tried to reach out to another hospital, but I cannot find teicoplanin. And also there was a story when the doctor in charge prescribed me the meropenem. The doctor in charge asked me to find the original name of the meropenem called meronem. It was very hard at the time to find it, and it cost a lot. I tried to reach out to many hospitals to find the original brand name of the meropenem, and then finally I found it one, and it was very expensive. For meropenem, for the generic was about not more than $2 per vial, but for the meronem, it was almost $60 per vial. So I had to purchase it for the original brand name because the doctor in charge asked me to do it. And then after 2 months of admission in the hospital, there was still no improvement of my child. My child did not gain weight. He still kept vomiting, and then he kept diarrhea. The diarrhea and the vomiting will stop if my child was keep fasting. So if my child was giving the total parental nutrition, my son keep would not have another sign of the diarrhea and vomiting. So after 2 months, I tried to talk to the doctor in charge. Was there another diagnosis than infection? Because I see that the doctors always diagnose my child as an infectious septic, but still no improvement with several kinds of antibiotics. So after that, we try to think another option of the diagnosis, and then we agree to test my child genetic test. So I sent my son blood to the German at that time, and I have to wait about 6 weeks, and then after 6 weeks, the genetic results show mutations in my sons that cause congenital short bowel syndromes. It means that it means that my child cannot tolerate for any kind of milk, whether it is a breast milk, cannot tolerate, or any kind of formula milk. So the case report shows that the child with these congenital short bowel syndromes depends with the total parenteral nutrition. So from this history of my son, I think that I can learn some point. At first, my son was given multi-course of antibiotics without an appropriate diagnosis, and also there is a communication barriers between healthcare providers and the patients. Although I'm a pediatrician, I still has a barrier in communicate with the doctor in charge. And also there are lack of availability and affordability of antibiotics in some of area, also in my place. Next slide, please. Next slide, please. And also these are some impacts that I have at the time, financial, of course, and productivity, of course. But the biggest impact is depressions. As a father and also as a pediatrician, I was depressed because I can cure another patient, another child, but I cannot cure my own son. It was very depressing at that time. Next slide, please. And then I will try to speak as a pediatrician. I work in the PICU in one of the referral hospital in Jakarta. Many of my patients suffer from infectious disease, and many also almost my patient also had multiple invasive procedures such as ventilator and central line. Next slide. And these risk factors make my patient have a tendency to suffer from multi-drug resistant bacteria. Next slide. And the impact of the as a pediatrician, of course, the patients with the multi-drug resistant bacteria will have a prolonged admission. Some of my patients have to stay in the hospital for more than 3 months, and also the cost of the third line or the second line of therapeutic is very expensive, and some of them will die because of the poor prognosis. Next slide. And these are some examples. Just last week, I had a patient with MRSA infections. I treated with vancomycin for 10 days, but after that, the patient still did not improve and died because of the septic shock. Next slide. And then this is an example, the culture from the catheter device, from the central line device. It shows a Klebsiella pneumonia with multi-drug resistance. So at that time, we tried to give him tigecycline to treat the Klebsiella pneumonia, but the result also did not improve. Next slide. So the problems and challenge that I find in my place is I divided in two, in the consumer side and the health professional side. For one is the awareness. For the health consumers, they might do not know about AMR or they do not care about the AMR. The consumer always asks the doctors to prescribe the best drugs. And then for the health professionals, maybe they know about the AMR, but they do not care about it. And for the specimen culture, the consumer do not know what is it, but the health professional know about the specimen culture, that we need to do the specimen culture to provide some alternative of the antibiotics. But many of the health professionals will not do the specimen culture because of expensive, and especially in the private sectors. And the consumer health in the private sectors commonly mainly they are middle up class. So it means that they have big money. So they think that by having a big money, by having a huge money, they can buy the best drug, and by purchasing the best drug, it means that their children get better and better than if they prescribe it with the generic one, because the consumer and the health professional both sides feel that brand name or Me Too drugs are better than the generic one. Next slide, please. And also the problems, and one of the problems is about the hospital-acquired infections. I think hospital-acquired infection still rise in some countries, especially in Indonesia. So it is very challenging to stop the rise of the hospital-acquired infection. Next slide. So as a conclusion, AMR is real and it is killing people. It is, for example, it kills my sons because of it. And the awareness about the AMR is still poor. I think there's some action that we can provide. First, we have to raise the health literacy. to the consumer and also to the health professionals. We have to decide to find the proper diagnosis before treatment, not always labeling sepsis, not always labeling infections to children that have fever. And then we also have to comply to the guidelines, and maybe we have to force a law not to purchase antibiotics without prescriptions. I think that's all my presentations. Thank you. I hand over to the moderator.
Dr. Lau, thank you so much for sharing your painful journey and highlighting so many issues that we have discussed and need to continue to discuss, both, you know, from your personal perspective, but also professional perspective as well. You've provided tremendous insight. I'm going to turn it over to Dr. Jason Newland, our vice chair, but also resident pediatrician, so he can give a few comments.
Dr. Lau, thank you so much. I know at the beginning you apologized for your English. Your English was perfectly clear, understood every word, and your passion and your story resonated very well in the room. Your child's story brings back too many memories of what we see in our own children's hospitals here in the United States. However, we don't tell our families to go buy meropenem and bring it to the hospital to be given. That highlight, I hope we all hear, especially in this room as we move forward through the day. The second piece I'd like to just highlight, Dr. Lau, that you so eloquently showed in your own practice as a pediatric intensive care unit physician in your country, and you demonstrated those susceptibility reports. And you showed MRSA, which we all know and we've all seen, and we know that's been part of it. But you talked about vancomycin, and you didn't have any susceptibilities for drugs like daptomycin or ceftaroline. Again, access, right? Like you're not even considering that. And then lastly, you showed Serratia. And you showed a Serratia that was resistant to everything on your list, but you didn't show drugs like ceftriaxone or meropenem vaborbactam. And so I think you highlight what we all need to keep in mind is that there is the access. And I think I probably lastly would say is you highlight the importance of prevention and that prevention of hospital-acquired infections, which I'm sure you are concerned about with your own child and needing to be on TPN and a central line and the infections that could occur with that demonstrates that if we can prevent people needing antibiotics, whether that's because they don't have a cold because they got a vaccine or they don't, you know, have a central line because they don't need it anymore. I mean, all these prevention efforts will impact our antibiotics probably greater than trying to find more and more antibiotics, because that's a hard thing to do. So I'll just end and say thank you for highlighting, I would say, almost our whole future report in one patient story from a healthcare provider and caregiver in such an eloquent, beautiful way. So thank you, Dr. Lau.
We
Thank you,
appreciate you
Dr.
joining
Jason.
us. Thank you so much again for sharing your story with us. And unfortunately, we've heard the same story multiple times as well with other patient stories that we bring to the council. And hopefully we have some sort of impact in this report. Moving on to the body of our agenda, I'd like to turn it over to Dr. Julie Simzak so we can start our panels and conversation. And you're welcome to stay and listen into the proceedings. Thank you again for joining, and good night if you leave.
Good morning, everyone. Our first
Thank
panel
you.
today will explore the role of education, knowledge, and behavior on efforts to combat AMR, both domestically and internationally. We have a really excellent lineup of speakers joining us today, and I'd really like to thank each of them for taking the time to prepare a presentation and to share their expertise with us. First, we'll be hearing from Professor Miroslav Sirota from the University of Essex Department of Psychology. Then we'll have a presentation from Mr. Courtney Price, who is the lead for behavioral science at the UN Food and Agriculture Organization. And we'll round out our panel with a final presentation from Professor Emeritus Otto Kars, the founder of React Action on Antibiotic Resistance. So please go ahead whenever you're ready, Professor Sirota.
Thank you very much. I expect there will be some slides. Perfect. Thank you very much. So, good morning, everybody. Good afternoon, if you're in Europe or somewhere else. I'm a professor of psychology, but also a co-founder of the Antimicrobial Behavior and Cognition Network. And I'm really grateful for this opportunity to talk about the critical role that social and behavioral science can play in tackling AMR. And I will do a very simple argument. I will argue that behavioral science has a valuable toolkit to fight pandemics that has not been broadly applied to antimicrobial resistance. And I will further explore the barriers and what we can do to facilitate the broader engagement of behavioral science into tackling AMR, and how behavior could become on a research agenda of AMR. Next slide, please. So as we all know, AMR is a very complex issue, encompassing or spanning across all human beings, animals, plants, and environment. And I like this scheme that shows the reservoirs and pathways of AMR development and spreading AMR, because we can see that the central and key aspects in this One Health approach is the human behavior, and that human behavior could mean overusing antibiotics in healthcare setting or overprescribing antibiotics in healthcare settings, but also overusing antibiotics in plant and animal production, as well as disposing unused antibiotics and generating waste from agriculture runoff or pharmaceutical manufacturing. And these, of course, involve other things and other behaviors, such as concerning infection prevention and infection control. Next slide. It is therefore very surprising that given the central role of human behavior, the antimicrobial resistance has not attracted a lot of attention from social and behavioral sciences. Here, what you can see is a number of publications published in journal indexed in Social Science Citation Index, and you can see a huge engagement during the COVID pandemic. These are the publications shown in pink. And a lot of research was generated by social and behavioral sciences on COVID. And a nice synthesis of useful evidence for policy during the COVID pandemic from behavioral science is summarized in this paper recently published in Nature. In contrast, we can see that there is an untapped potential for social and behavioral sciences to be applied to the issue of antimicrobial resistance. Next slide. Just to be a bit more specific, I'll give you a few examples. It is well known that in primary care, antibiotic expectations drive overprescribing. And some meta-analyses show that over 56% of parents expect antibiotics for children with upper respiratory tract infections. However, when you look at the clinical trials trying to curb overprescribing in doctors, this is rarely addressed as a topic of the trial. There are a few exceptions, of course, but given that it's the main source of overprescribing, it's very surprising that this is not tackled in much more systematic way. So the question is why? Well, because we don't have a good understanding how people actually form expectations, and we don't have good understanding what is happening during the consultation with the doctors. Next slide. We can leverage some of the methods of the toolkit of behavioral science. I'll just give you two very different examples. So this one comes from my research, where we can actually leverage the frameworks of cognitive psychology and use cognitive computational modeling and actually model the expectations, try to decompose them into, is it just the mere inability to discern the infections that require antibiotic from those that do not require them, or is there a systematic bias or tendency of people expect antibiotics for everything? We can understand what are the drivers behind that antibiotic decision making. And as a matter of fact, what we are finding, it's mainly driven, people's expectations in the UK is mainly driven by the sheer diagnostic uncertainty that they have when they are encountering certain symptoms. But of course, this will differ across the environment, and it's much more complex issue. Another example is two American sociologists did this very interesting study in which they analyze the interactions between patients and family doctors when people were presenting with upper respiratory tract infections, right? And they found that yes, people can ask directly for antibiotics, but this is rarely the case. They have much more elaborated strategies and behaviors that engage doctor during problem presentation, the way they present the problem, during information gathering, nudging doctors to prescribe antibiotics, or during counseling, resisting when they are not prescribed antibiotics. So we need to understand deeper what's going on the behavioral level, on cognitive level, to be better to tackle these things in clinical trials. Next slide. Well, of course, there are plenty of other examples, and some of them we will hear from our excellent speakers after. What information to provide in public health campaigns. We don't have a comprehensive research on this. There is a Wellcome Trust report on reframing AMR. That is a very good start, but it's mostly based on qualitative and survey evidence, but we can also have and build a large systematic experimental database of the findings to understand what information to provide to the public, what kind of terminology should we use. A great research from Eva Krokov about which terms we should actually use to communicate about AMR to the public. The recent research where we show that the popular term of silent pandemic can actually have detrimental effects on perceived riskiness of the pandemic when accompanied with the intended meaning. And of course, then we have questions about how to encourage behaviors that foster biosecurity in poultry farms and other issues that are addressed in other countries and that are more pressing in Global South. And we will hear more about it from Annika and Courtney. And just to say, this is not only targeting individual behaviors, but also leverage the insight of behavioral science to support any systematic changes. Next slide. So I want to just briefly discuss what could facilitate the engagement, the broader engagement of behavioral scientists. First, raising awareness about AMR between or among social and behavioral scientists, but also importance of behaviors among other AMR experts and clinicians. Second, defining social and behavioral science research agenda on AMR. I mean, the engagement, it's impeded also because a lot of social and behavioral sciences do not understand what kind of behaviors should be actually tackled, right? So currently working with some experts to trying to identify research priorities that would address human cognition and behaviors related to AMR spread and containment. So what we need is well-defined, structured research agenda that would reflect the different needs of different countries, when we simplify that, of the global north and the global south. Next slide. And of course, we need to build more interdisciplinary collaboration that go beyond certain disciplines, because this is a complex issue. I think the behavioral scientists should be more represented in relevant advisory boards, panels, and groups. And we have seen this during the COVID pandemic. You can have technological solutions to the issue, such as vaccine, but you also need to have support of behavioral sciences to encourage the uptake of the vaccine. And for that reason, we also created this network, and everybody's free to join and explore, where we try to facilitate formation of these interdisciplinary teams and collaborations and exchange of informations. Next slide. And of course, enhancing incentive structure for social and behavioral scientists to engage into AMR research will be as important. I think partly it will be driven by the intrinsic motivation when they understand that this is really an important problem to tackle. But also we need to create more opportunities for extrinsic incentives, such as funding opportunities. Next slide. So by integrating social and behavioral science, I think we can develop more effective strategies to combat this crisis. Thank you very much for your attention.
You can start next, Courtney.
Great. Thank you. Wow, it's really great to be here, and it's an honor to follow Miroslav and be part of this panel. Thank you so much for the opportunity. And I'm really excited to share with you the opportunity FAO and partners have been exploring the last few years around unlocking the power of participatory behavioral science. And you'll hear a lot of, I think it's great to build on what Professor Sorda was talking about around the need to increase our investment, understanding, and normalization of these sciences in our daily work. So we'll talk about a few examples across the global south around behavior change research on the One Health spectrum, but these examples definitely have insights for all countries, and it's a critical area where the US can definitely take a leadership role. Next. I should say that it's really important. I'm really honored to be joined by my colleague and behavioral science expert, Annika Bukel, because without Ms. Bukel and the energetic engagement of FAO's Animal Health Service, many of these examples would not be possible. Before I dive in, let me start by just kind of giving a statement of the obvious. Behavior is everything. I mean, AMR is complicated, don't get me wrong, and that complexity is really important. We need to honor it. But it's important also to see that underpinning all the challenges we face and essential to all the success we hope to have is really what people do. So behavior is really essential, and taking it into consideration and knowing how it works and how to influence it for good is a critical and urgent need. Next. Now, COVID-19 brought with it a great many impacts, but one of the positive ones, I would argue, was it gave us a teachable moment on behavior change. And that teachable moment was about really coming face to face with the cognitive dissonance of knowing what we need to do to fight the virus, to not get infected, to not spread it to our friends and family, and sometimes really struggling to do those things. Now, there was a lot of other factors involved. There was a lot of discourse and discord, but even when we knew what to do and we intended to do it, that was surprisingly hard to many of us. Now, I think it's best to show and not tell, so let me just let the experts give us really drive this point home. Next slide. This is a video clip of public health experts telling the public early on in the pandemic why they should not touch their face. Click next we'll start it.
Start working on not touching your face, because one main way viruses spread is when you touch your own mouth, nose, or eyes. And of course, enhanced cleaning of surfaces.
I've been looking around the room here. I can't tell you the number of you who've put your hands to your face in the last 20 minutes or half an hour.
I want to know how many of them are from...
Don't touch your face. My kids are so sick and tired of me saying if they scratch their face, don't touch your face.
Okay, so I don't know if you could see through the video through Zoom. Sometimes compression is a challenge, but we have all these experts, sometimes double PhDs, telling us not to do the very thing that then they struggle to avoid doing, which is touching their face. So this is a really interesting, conundrum. The next slide.
Start working.
So we need to think about what the lesson is here. And, I think it's really clear, the knowledge and awareness are often not enough to drive change. Even when we're experts and we intimately know what to do, we struggle to do it. Next. And I think it's also important to take this chance to move from COVID-19 to AMR and other aspects of One Health. Next slide. And this lesson is true also for farmers. Extensive research. Oh, sorry, previous slide. I apologize. There's a delay on my side, I think. Okay, I apologize. Can you go back? Okay, this is the correct slide. Thank you. Sorry. So this is a knowledge attitudes practices study implemented by FAO in 2020, and extensive research across 5 African countries showed that even when farmers knew, and most did, understand antimicrobial resistance, know the benefits of biosecurity practices, etc., that knowledge didn't correlate with their practices. They didn't do the things that they said they wanted to do or said they valued and knew. Next slide. So this is really, to drive home the point, this idea of this disconnect and how we can address it is really an opportunity hiding in plain sight. These examples and many more, really unveil this important decision we need to make as a scientific community that's working on AMR. Not sure if this next slide is showing up for you. It should be the diagram of context.
Yep, we see that.
I don't see it on my side. I apologize. Okay. This lesson. So this opportunity hiding in plain sight, really, and relatively untapped, as the previous speaker mentioned, is really to flip the script on how we think about change. Our opportunity and urgent need is to reinvent how we as a society to attempt to influence behavior for the good of people and planet. Our traditional approaches, while they have been evolving and are extremely valuable, often target the concept of mindset or attitude. They often really work on awareness and intention. And those are all very important aspects of how, and they do have really critical influences on behavior. But I think the untapped opportunity really is to look at how context, physical, social, environmental context, what behavioral scientists call choice architecture, really can influence and drive behaviors. And for example, in the COVID-19 pandemic, we had so many examples of these contexts going wrong, where it was either harder to do the thing we wanted to do or easier to do the thing we weren't supposed to do. And for FAO's perspective, the really nuanced but important aspect of this opportunity is really that it be locally driven, that it's community driven, that it's a collaboration. And the key word I'd like to leave with you today is that of co-design. Next slide. So how do we change context? How do we work on, moving not beyond persuasive argumentation, advocacy, knowledge awareness, but in addition to our knowledge work? How can we change this context? And the answer really is to apply behavioral science. And, I think it's very important from the get-go, behavioral science or the behavioral sciences, it's hard, you can argue about what they are, but basically the approach of applying behavior, from understanding behavior and trying to influence it based on what we really know about how actual human beings work. It's a multidisciplinary approach, and really importantly, it stresses evidence. It stresses experimentation. It stresses, moving beyond intuitive, feel-good interventions where we feel like, wow, this communication campaign was really great, where we actually have data to back up that whatever we're doing is influencing and pushing the needle in the right direction. And most importantly, is from my side, from FAO's point of view, that this experimentation is done together with stakeholders as equal partners in change. Next slide. So fortunately, I'm sorry I'm delayed. Fortunately, human health really took the hint during COVID-19, and I'll just gloss over the details to say COVID-19 was a difficult time, on so many levels, but we saw, lots of use of behavioral science, some successful, some not, in the environment. I don't know how many of you can remember singing perhaps a song with your kids to try to ensure that the hand washing period was 40 seconds in order to kill the virus. These kind of examples where it made it easier to do the right thing, that was pervasive. And then we had, the Technical Advisory Group from WHO, we had many others, USAID in particular, and the UN Secretary General joining forces to really call for more behavioral sciences across development, and even behavioral science applied to AMR, especially in the public health area, started to crop up later with some tools and approaches. And there was relatively limited in application in the global south. Next. And this is where I think the opportunity is really important to note that we are having such a gap with regard to other aspects of One Health, animal and environmental health. These elements really have struggled to uptake this lesson from COVID, that behavioral design and context are really a key part of our toolkit. And without them, we're kind of fighting AMR with one hand tied behind our back. Next. Just one of two examples I'd like to share with you from the FAO side to try to contextualize this opportunity. This one is a pilot done in Mozambique, where we worked with some control and some treatment slaughterhouses, where the control groups went through a participatory process of learning behavioral science, co-designing a solution for themselves. And what they came up with was deceptively simple. It was color-coded buckets, a streamlined system. But the difference for this was this proposal, this idea was not parachuted in from some other place. It wasn't read off of a textbook from another country. This was a design that came out of the natural discussion of why I don't do the thing I want to do. Most of the slaughterhouse workers confirmed they wanted to be efficient. They wanted to keep clean areas cleaner. They wanted to boost productivity. They wanted to have more fun while they worked, and then be cleaning less often. These things were all part of their intentions, and we unlocked those actions by leveraging behavioral science together. This before-after experiment showed a whole lot of interesting impacts, but one critical one was that hand washing went for something around 10% all the way to 95%. Sorry, I think we've gone back a slide. Apologize for the technical difficulties. Okay, here we are. The second example I'd like to share with you is the Farmer Field School example, but a nuanced and a new version of Farmer Field Schools that FAO has been piloting with the help of Amica and others, and that is injecting behavioral science into this community-driven approach for change. In Ghana, this problem was all about really using disinfectant foot baths properly. And as a result of going through the co-design process and testing results as a community, farmers got, not only did they use the foot bath more often, buy disinfectant before it ran out, use less disinfectant and save money, they also became really change makers of the participants in their own change. And this resulted in huge amounts of awareness and sharing when people visited the farm. So we saw a potential for scaling here, where this kind of community movement of finding a change, testing it together, and spreading it really gives us the opportunity for scale. Next, and I'm wrapping up. So basically, I think what we see from these examples and many, many more is that behavioral science is a critical tool, and we just haven't been using it sufficiently, especially in animal health and environmental health. And I'd like to be provocative here by saying it's not just about farmers in their fields, consumers at the supermarket, food processors or vendors. It's also about upstream behaviors. If we really stop to think about it, One Health collaboration is a behavioral problem. Research systems, encouraging, incentivizing more research in behavioral sciences around AMR is also a behavioral problem. There could be other areas that we could design and increase, not only in incentives, but also in structures, processes, and systems that just make it easier for us to do more behavioral science research. And finally, even siloed thinking and the unfortunate pervasiveness of silos across the different One Health spectrums don't have to be broken down only by awareness, which hasn't really worked, even though we've known they need to be broken down. But we need to adjust how we do the business of One Health using a behavioral lens, and perhaps we could really make progress in that area as well. So in wrapping up, I'd like to say, next slide, that this amazing and powerful work on raising awareness, increasing knowledge, building capacity needs to continue. But where awareness raising falls short, behavioral science is there to help us develop evidence and leverage really a really powerful mechanism for change. And that is just the context of our daily lives, the choice architecture around decisions that can make the right choice, the easy choice. And I'm really excited to, look to work with FAO and others, the United States and many other countries on gathering together to leverage this opportunity to more effectively fight AMR and use all tools at our disposal. If we continue to use older methods and don't invest in newer methods, we can't expect new results. Thank you very much.
Thank you so much, Dr. Price. We appreciate your presentation, and apologies again for the technical difficulties. For our speakers, just a reminder, please do not use the live stream. There is a lag between the HHS.gov versus what you see directly on the Zoom, so please use the Zoom screen. Next, Dr. Kars, thank you for joining us.
Thank you very much. I'm really happy to be part of this panel, and I will absolutely, you will see, I will echo many of the important messages from the previous two speakers. I'm not a behavioral science. I'm an infectious disease physician from the outset. Then I moved into policy work in Sweden and then internationally. So next slide, please. REACT is an independent international network supported by the Swedish International Development Agency. So we're focusing on low and middle income countries. We started by increasing the visibility of the antibiotics in the global arena, tried to translate this difficult issue into something that is understandable both for policymakers and for people. But we're now focusing even more on supporting development of implementation national action plans in some countries, specifically Africa, and catalyzing action for behavioral change and civil society mobilization. There is a lot to do here. And when hearing the tragic patient story in the start here, I mean, the words that comes to my mind is urgency and behavior change. We're not very many, but we have nodes, what we call it in REACT Latin America, in Ecuador, and in Zambia in Africa, and in Asia Pacific, Kerala. Next slide, please. I'll try to summarize a little bit. Next slide, please. To summarize a little bit my view of the many years I've been working on this, I had a conversation with Keiji Fukuda, who was the Assistant Director General in 2009 and 2016 at the WHO. We had collaborations over that time. And he told me that he saw the development of actions against antibiotic resistance, or AMR, as three waves. The first is science. And if you look into PubMed, or the databases, you can see that in 1995, there started to be an exponential growth of articles on these issues. Then came political awareness. So there was a spillover and understanding of the political level, both nationally, but notably for sure globally, with the climax on the Global Action Plan in 2015. But what we are really missing out here is an engagement of whole of society, engagement, change in behavior and social norms. And this needs to happen. And one barrier that we have already heard about, but I will reinforce a little bit, is that the flow from research to policy to civil society is hampered by the language, hampered by the narrative, which is not well understood. Next slide, please. Just to underpin a little bit of these three waves, there are 70. Last year there was 70,000 PubMed hits using the terms antimicrobial or antibiotic resistance. So what I think the message is here, but let's say a tenth of those were including social and behavioral science, and that was also alluded by Miroslav earlier, that this is really a missing piece in the puzzle. So we have science, but maybe we don't have the right science, or at least there are significant gaps in the science. I was in an independent group called the ICG, International Coordination Group on AMR, for some years, and we proposed that an independent evidence panel should urgently come in place, and that has not happened yet. It should be coming soon. I think that would help a lot and push for the gaps. Now, on the political awareness, it's amazing to see that 170 countries have a national action plan in place. That's an enormous progress. But if you look at upon the figure that only 10 of these are budgeted, and in fact, in Africa, 0 has a budgeted plan. We are still far from where we need to be. And regarding the society, the engagement and understanding, as also earlier was alluded to, there is a lot of illiteracy here still, where in many countries, more than 50% thinks and that antibiotics kills viruses. And if you compare this with another crisis, the climate crisis, I think there are substantial analogies to be made here, in fact. A 2-year real-time data collection showed that 71 tweets, or what they call it now, X's, discussed AMR, while 3.5 million discussed climate change. So we need to move much more into society, have a bottom-up approach and an understanding to underpin the real changes that need to happen. Next, please. So just 2 recent articles echoing what I said and calling for an independent panel, a recent analysis or at least a critic maybe on the limitations that we have on the global governance today. And one article that is really having a very strong message from a colleague of Miroslav in the UK, the rebranding of global health threat like AMR requires large-scale unified campaign led by a unified group of psychologists and perhaps led by WHO. Next, please. So Wellcome Trust was mentioned before. Wellcome Trust has produced numerous, not numerous, but several really good analysis on rebranding or reframing AMR language. And at the bottom, I think the most important thing is to make people understand what is at stake for them as individuals. It's not only as a global crisis that may come or they have difficult to grasp, but really what is happening in your body with your microbiome, and what is really at stake. And the next slide shows a pyramid that we are using to explain this to people and also to politicians. Antibiotics underpins everything in health. The weakest systems, the strongest systems, modern medicine, basic medicine, and on top is cancer treatment. We know that 10% of cancer patients die from sepsis, not from their cancer. So modern medicine is at stake, but also basic medicine. And we need to see antibiotics as infrastructure, pieces of infrastructure in the health system. Next, please. Just a few to end with some few examples from Sweden here. We have a professional-led strategic program on antibiotic resistance since many years, and you can see the downward trends on antibiotic use in all age groups, particularly starting with the children. We also have a project called Antibiotic Smart Sweden, where we try to reach out to all of the society in hospitals, primary health care, schools, preschools, with indicators and interventions that make everyone understand the problem and deal with it in their way. The next one is from Latin America, where it's grounded really in the One Health thinking, where there is an understanding about the relations between food, environment, health, and they're working very much with children. So this is the Arforsa. It's an educational tool to children education, which is used now in many schools and used to start from young ages, and also empowering communities together with PAHO is another series of webinars and projects that makes also an outreach to civil society at large. Next is from Africa. You will all find all this in our website. So next, please. React Africa has been more focusing on the policy level, where there is a great meeting every year, a summit where policymakers, researchers, agencies around Africa are meeting to share knowledge and experiences. But also the group in Africa is supporting many of the African countries with the implementation of the national action plans, which is a real challenge. And lastly, React Asia Pacific. Next, please. Next slide, please. Yeah, thank you. Are working in communities. And I think the handbook they have produced here could be a really valuable tool for communities to engage local governments and have an indicator framework to really measure the progress in the community so determine the effect of the interventions that will lead to a better understanding, and this is also in the One Health perspective. Next, please. So to wrap up, we have a problem with science to policy. We have a problem between policy and implementation. We have a problem with short-term projects, and that is specifically true for low-income countries where there is so little funding. They have to shop around to get some funding for projects, and the serious crisis we have need to have a much more longer-term funding that you can do it in a systematic way and based on need and priorities. So we have a fragmentation and integration problem as well. Next, please. On my wish list here, because we are heading now to a very important meeting in September in New York, the second high-level meeting on AMR, which will take place in September. And these are some of the asks or wishes that we have been put forward from REACT. I think we need to agree on a common vision that could drive the pathway to all work that everyone is doing. We need to share responsibility for preserving a critical public good. This could be one way of framing it. Sustainable access to effective antibiotics for all is another one. So changing the language towards a much more meaningful people-centered narrative and not a fear-mongering one, I think is the way forward. And certainly strengthening the voice of civil society and professional organizations and include them more formally in the implementation of the work. Financial support is absolutely needed, critically needed for the low and middle income countries, and this must be a obvious responsibility for the rich countries. So next slide is the last one, is just showing the toolbox we have in REACT, which is a resource that with numerous selected articles in different boxes. And where also we have reference to the projects that I've been alluding to. So thank you very much.
Wonderful. Thank you so much to all the speakers for the really interesting talks. Now we're going to transition to our council discussion period. And as a reminder, if you have a question, please put your your name tag up like this. Yep. And I will call on you in the order that we do that. And so I see we have Paul with a question. So Paul, go ahead.
All right, thank you. Really appreciate all three of the presentations. I think this area of awareness, behavioral science, communication is critically important, and we've highlighted that in almost all of our reports in the past, and I think it remains a critically important component as we move forward. In particular, I wanted to follow up, Courtney, with you. Appreciate in your last slide kind of the comment on behavioral science as it relates to implementation of One Health. And obviously, One Health is important to PACCARB. We strive, as we heard earlier today, we strive to do One Health in our report. So I'm interested, Courtney, if you could dive in just briefly a little bit deeper into how you see behavioral science, what shortcomings are there, or how can behavioral science help with that?
Certainly. Thank you, Dr. Plummer, and appreciate the question. I think once we start to think behaviorally, we can see that a lot of our systems and processes that attempt to drive an optimal outcome from a behavioral perspective sometimes do the opposite. It's very classic examples of, trying to get people to pay taxes on time when actually the fine to get the tax fine costs the government more to disseminate than they receive, and ends up making the process more difficult. So when it comes to collaboration, we have to unpack that term in terms of critical behavioral cascades or areas of work. But one thing's for certain, that our intention to do One Health is there, and our knowledge of how important it is there. But maybe we're not designing systems and processes in a way that make those follow-up behaviors easier. So examples include just the way we hold meetings, the design of our research proposals, the composition of our expert panels, sometimes checklists, reminders, and other tools like that. We often think of them being applied to consumers, to public health down the line, or doctors, but defaults, checklists, and other systems can be used to change the way we do the business of One Health. So without getting into too much minutia, I would say the main opportunity here is to use an additional lens to understanding why certain collaborative behaviors don't happen, the frictions that are inherent that have nothing to do with our intention, but are just sometimes bureaucracy, sometimes process, or systems that are outdated or haven't been reviewed, and see how we can change the process so it makes it more likely for the people that need to collaborate to be gathering in that room, virtual or real, to do said collaboration. So the opportunity really is to address barriers to collaboration from a behavioral perspective, not just from a knowledge, awareness, and rational perspective.
Great, thank you. I think Tim was next.
Great. I want to echo the thanks to all the speakers, but I also want to add, in particular, thanks to Professor Kars for his longstanding leadership in this space and bringing the focus to the impact of AMR on people in low and middle income countries. So I have a couple of questions, and the first one I want to direct to Courtney, and you mentioned the opportunity for massive scale up. And I wonder if you could speak to what that could look like. Is the scale up around the engagement of people in the design, or the implementation in designed programs and projects that have been developed within communities? There are possibly two different angles here, and be good to understand what massive scale up looks like. And I have another question for Professor Kars on changing the language, and if you could share some additional thoughts and insights on what that needs to look like, particularly getting away from this group around the table, or a bunch of experts, and we're fairly comfortable in our jargon. But really, can you push us harder on what we need to see happening to change language, particularly for global engagement? Thank you.
Thank you for the question. I think I'll respond with a big picture, and maybe pass over to my colleague Annika for a little bit of more examples. But I fully agree with you. There are definitely two angles to this, and they're both critically important. And I meant that massive scale opportunity in both senses. But full transparency, the massive scaling up of behavioral levers is rare, because behavioral change is so contextualized. Famous examples include defaults on, the Save More Tomorrow program is now quite old. The idea that we add a default mechanism in how people sign up for their next contract in their job that automatically opts them in to their savings, to their pension plan. There's not a whole lot of these examples because they're hard to find, and they're hard to see behavioral levers that apply across large contexts. So specific example I'd like to take that is purely hypothetical at this moment. We haven't been able to push these discussions any further, but it came out of a behavioral science process, was that foot bath example I gave you. One of the barriers to correct disinfection, correct dilution of foot baths was literacy and complexity, cognitive, just noise around the amount of disinfectant to dilute into how much water. And this is just a practical challenge that a lot of farmers face. A scalable example of that problem, we came up with the community came up with an easier to remember rule of thumb for effective dilution of said disinfectant, and a scalable policy recommendation that would be generated as a result of this could be to regulate the complexity of disinfectants, to look at contextualized application of disinfectant rules and regulations that would scale up across a community and be viable for multiple stakeholders or even countries. When it comes to, but like I said, it's really rare to find those scalable levers. I think the main idea was captured. You captured in your first point was, we love to talk about copy pasting and intervention. Let's do this kind of communication campaign was so useful in this country. Let's do it in that country. Or this kind of behavioral change mechanism seemed to work. Let's scale it up. But what I'm talking about is exactly what you said. Copying the method, not the nudge. So getting people involved in participatory co-design is in and of itself a behavior change experience. And it's also a humbling experience for quote unquote experts, because you're not coming in with a solution, you're coming in with a toolkit of options and you're co-creating that solution. And the reason it's scalable is because it has this sense of co-ownership that is created and engagement across communities. And when you have something like farmer field schools, which are in some places FAO is fortunate to have been engaged in several hundred different communities across districts and even countries, that is a place where you can take this test of a nudge and this participatory design and rapidly test in other places and build a community level approach of applying behavioral design. And I believe the more we think behaviorally about all problems, the less frictions we're going to have, because adapting to how people actually work is really critical to solving problems. And we tend to stay very high. We tend to overemphasize that rational process and not just making it the best practice easier. But I meant to give more time to you, Annika, if there are any specific examples or ideas you'd like to share or nuances on the answer I just gave. Apologies.
No. It's all good for me personally that I work more in the global south, low middle income countries. I think the aspect of ownership is really critical, and it's really appreciated also by the people we work with. That we are not just coming with ready-made solution that has nothing to do with their context, that they really are asked their opinion, the context in which they live, the problems they face, which are quite unique. We really don't have an idea that they feel acknowledged and that they have this ownership component, which of course, if we just take this nudge or this intervention, copy paste it, we take that away, and I think that would limit the effectiveness of the intervention. Thank you.
Thank you for the question on the narrative. Well, it's a big one. Of course, AMR is fairly well understood, I think, in the policy circles today and what we call the AMR community, although there is some divide also in those circles. For example, between antibiotic resistance and antimicrobial resistance, the wider perspective. But anyway, when you reach out to people, and that evidence is clear now from the study that Miroslav was also mentioning, that AMR is lowest on the list of health terms to be remembered by people. So if we really believe that we must engage civil society, people and networks and civil society organizations, we really need to make them understand what this is all about. We need to change behavior, social norms, not the least the demand, the unnecessary demand, perceived demand on antibiotic treatments and shopping in these countries. So having said that, I think this is not an easy transition to make. In the very important O'Neill review, I think it was in 2016, if I remember correctly, there was a call for a massive educational awareness campaign. We don't have that. We have a word AMR Awareness Week, There might be very important local and national attempts, but I think this is a very important missing piece in the whole puzzle. And these campaigns need, of course, be based in science, in behavioral science, and they need to include messages that are tested locally. Context is absolutely important. Culture is important. Beliefs are important. So this is something that need to start. And the bridge between the really important stuff that you have done in Welcome Trust for several times, to bridge that to resourcing behavior scientists, and then coming up with new ways of describing it. But basically what I think is we need to move away from fear-mongering, if you like superbugs, war on bacteria, which in fact could increase the perceived need for antibiotic use, if there is a fear factor, towards something more hopeful, something that we all can agree upon. We need to save and secure the existence of antibiotics in all health systems for as long as we use them. We hope that might be in 50 years' time, there might be something else, but it doesn't look good. So, I mean, preserving this global resource, I think, is something that we can unify on, and that. But how to really sort of simply, in a simplistic terms, come up with the term, I don't think that's possible. It needs to be another kind of more elaborated narrative, but it should definitely build on diseases that people think of and know. And AMR is not a disease, and that's one of the problems. This is one of the problems why we haven't got further. One of the problems why we didn't get funding, and so forth. So it's not my expertise, but I call, and we heard the previous speakers also. This is really an important area and a missed one. Thank you.
Wonderful, Francisco.
Now the tent is down.
Yes.
Thank you very much for educating us in a topic that, at least personally, I know very little about. But I wanted to touch upon this subject of bringing information to the consumers. So the first question is for Miroslav. Recently, there was a survey by Forbes showing that 79% of Gen Z people in the United States find their financial information and advice. Sorry, is that better? Their financial advice from social media. Roughly half of that was from YouTube, the rest from, I believe it was Reddit, and then the rest of the platforms. So that is to make lifelong decisions about investment and other very important things to all of us. So I wonder, what is your experience or your advice when it comes to trying to use less traditional platforms like social media, perhaps even influencers, to create these changes? So that's for Miroslav, but also I'm sure for the other two panelists. I'm sorry, rather experts. Thank you.
Thank you very much for the question. I think it's an important one, and we touched upon the content of the information that we are providing, but certainly the channels of communication could be the object of the study as well. To make my answer short, we don't know, right? Because there is no research specific to AMR that would be testing this in a systematic way, and that's why I think we all are arguing for larger investment in this area so that we would have precise answers. We can sort of make inferences based on the other surrounding areas because there is research on vaccination, for example. So we know that, for example, vaccination informations, at least in the context of high-income countries, are most trustworthy when they are coming from health professionals, usually to local health professionals, local GPs, and so on. And of course, social media is also an important, or are important platforms to disseminate the information. WHO and during the AMR Awareness Week is disseminating information on Twitter, right, and on other social media. But it's really hard to answer precisely how this affects the consumer. But to give you a clear answer, we can, it could be the object of research, right? And that is the important aspect of what we are, I think, trying to argue here for.
Great. Okay. I think Lucas, you were up next.
Thank you. Thanks for such an interesting conversation. So I kind of throw this question out to maybe all the speakers, but there was this very interesting article last week in the Wall Street Journal about the incentive or monetary prices to enhance innovation. So there's these, people put up money to develop an innovation in a certain aspect of what they want to innovate, and they open source to bring people from different disciplines and collaborate. And they believe that has had, improved innovations in several areas. So what monetary prices, for example, at the local level, what impact could that have at changing behavior?
Well, I think this is apologies, colleagues. I definitely am not a behavioral economist, which sounds like a question for someone with that acumen. And it's probably not the answer we're all looking for, but I think it is the answer we need, and that is we would need to investigate the context, the specific context we're talking about. And I think what we're without, I'm dodging the question to some degree, but with purpose, and that is to highlight that the process of applied behavioral science is really championing this diagnosis phase in which we investigate why something isn't happening, and it would be then building a research question exactly around what Mr. Pantaleon mentioned, which is understanding why people aren't doing the thing that we want them to do, and if an economic incentive is likely, based on data, based on evidence, likely to have an impact, and then we would design a test to see how it could work. So that's an empty answer to your very, very pertinent and deep question. There are plenty of examples in the literature about how incentives function and their impact on us. But just as we don't want to pull intuitively jump the gun on a communication campaign, just as Dr. Kars so eloquently put, we need to test messages locally. So too do we need to test how economic incentives and interventions may have an impact. And there are various methods to do so. We don't always have to run extremely complicated, expensive randomized controlled trials, with especially when context specific, when context dictates, we can think about online experiments or other tools to have some insights into what will or will not influence behavior for good. So the thing I'd love to do is follow up on that question and get one of our behavioral economists working on a willingness to pay for food safety. Right now, if he was engaging in trying to understand and quantify what is this economic willingness to pay for the knowledge / sensation and perception that food is safe. So as you can see, that's a complex question. Similarly, what incentive economically will allow me to take a risk? Because innovation in and of itself is risky, and human beings are all risk averse to various degrees. So testing the risk aversion of our community in practice and trying to quantify what an economic incentive would do to help overcome said risk aversion would be a fascinating experiment.
Great. Jason, I think you're up next.
Thank you. Thanks for those speakers. I think this from Miroslav and Otto. Otto, you triggered this thought. We on the council have discussed in the past, is there a way to link something bigger or something more notable to AMR? Because I would argue most of our societal issues are related to AMR, whether you're in a refugee camp, you have the highest antimicrobial resistance, or you have, climate change and major disasters leading that. So I guess to you all, we're always looking for that single magic bullet, and I think Courtney, you demonstrated well, co-design is going to matter. But can we have some larger linkages like climate change, and will that have some impact as we try to message and elevate AMR for awareness?
Yeah, I think taking climate change first, I agree with you that there are links, and there will be even more visible over time when we are heating up the planet, that vectors are spreading, and with them also diseases, and also perhaps bacterial infections, bacteria will, and you know, the heat. So absolutely, there is a physical connection between AMR and climate change. It's not really visible. It's not really scientifically sort of pulled together yet, but it's there. But I think, for me, is the analogy with the problem itself is we have let's say, clean air and effective antibiotics as assets that we want to preserve, and this is a global effort, need to be a global common good, need to be done by everyone, every country, everyone, and also we can, you know, make the analogy with the transition of systems that need to happen to reduce the climate crisis, but also strengthen systems in health, agriculture, and environment to minimize the spread of AMR. And thirdly, to do that, we need to have a transformation fund or a catalytic fund to the low and middle income countries to make them start and speed up their work. So I think with that, I absolutely agree with you that there's a good link in terms of describing the problem as a bigger one than not just a technical one, and not something between a patient and a doctor or so. So I think that it's so big, it relates to everyone, every animal, every human being, every health system, everything. So if we put it in the center of the Sustainable Development Goals, we can see the links to most of the goals, or several of the goals are jeopardized by AMR. Some of the goals, if they are fulfilled, are in fact supporting the fight against AMR. So I think that would be a way, but that won't go so well with the public perhaps, but at least for policymakers, and not at least funders and finance ministers. Because we have to draw on all the assets that are already out there. I don't think that we can create a new fund. We should, but that's not possible. So that's my thing.
If I can just follow up on that, I think communication about AMR could be with some global team, but the information provided to public must be tailored to specific context. And even just when you take the European context, there are huge differences in the antibiotic use, awareness of antibiotic use among consumers, and there are different healthcare systems put in place. So any of the messaging needs to be contextualized, and perhaps there are messages that raise awareness and the sort of ability to discriminate between the infections that require antibiotic treatment or not when presenting to primary care, compared to the messaging that encourage people to just refrain for attending to the doctor, but have good discernment between these situations. And of course, then there is the great differences among the countries when we think of upon the dimension of the global north and global south. That requires very different set of policies put in place, very different set of communication and information that is relevant for the given cultural context.
Great, thank you. Lynn?
I very much appreciate the education that the speakers are giving us this morning, so thank you for that. Over my career, I've watched the investment community in general abandon the space. I've seen the talent exit the space, seen companies go bankrupt. Our pipelines are inadequate for the future challenges we face. We're less well prepared today than we were yesterday, and tomorrow we'll be less well prepared than we are today. The messaging that we've had so far isn't working, so I'm interested in this connectivity and linkage piece. Dr. Lau very clearly showed us the link between AMR, healthcare associated infections, and sepsis, which is a Venn diagram of overlap, yet each of our communities goes and messages, and each of those communities talks about how tough it is to get awareness and education and change in their spaces. I'd be curious as to Dr. Kars and the others, do you feel like there's value, maybe climate change as well, but in terms of the overlap and the connectivity between AMR, healthcare-associated infections, and sepsis, septic shock?
I had a little bit of a bad connection. I didn't really hear your full question, but I think you're related to the relation between AMR and health-associated, care-associated infections.
Yeah, just to clarify, the question is, rather than linking with global climate change, which may well be good, is there a value in bringing the communities around sepsis, septic shock, healthcare-associated infections, and the AMR messaging together as a collective? Do you see value in doing that?
I think, you're pointing on a very important thing, because these issues people understand. They know what sepsis is, they know what cancer is, they know what an infection in a hospital is, and obviously AMR is not driven only by overuse and misuse of antibiotics. It's driven by spread. It's really. I agree with Miroslav that we should perhaps stay away from the terminology of silent pandemic, but obviously it is a pandemic. You can clearly show that over time the same bacteria are traveling across all continents. So for sure, and that reinforces also the messages of personal hygiene, infection control practices, and all that need to be in place to really manage this. Prevention must come much stronger forward. It's not only about antibiotics. Really, the solution is not about antibiotics. In fact, let's say we cannot solve this problem, unfortunately. We cannot eradicate the problem as long as we use antibiotics. We just need to come in balance between, as you alluded to, R&D. We need to stimulate by novel incentives and in unprecedented global scientific collaboration, the pipeline. But that is not the solution. We need to plug the holes in the bucket. If we put antibiotics in a bucket with a lot of holes, it's not very cost effective. The holes are misuse, the holes are environmental sprayed, the holes are lack of wash and sanitation. So we need to put it in a way that we balance supply and demand, and then I think we can do that over time. We can balance supply and demand so that we will be able to treat infectious diseases and bacterial infections, but we need to speed up the actions.
I don't know if I can chime in, Dr. Kars, not just adding a tiny bit of nuance. I was thinking when you were speaking and when Lynn was asking the question that, the first rule of fighting AMR might be don't talk about AMR. Making something salient, making something attractive, available cognitively is a critical aspect of how we navigate the world. And we choose a lot of things based on stimuli, based on what's easier for our brain to recall. When things are complicated and let's say extremely valuable in their complexity, but as I alluded to in my presentation, sometimes that complexity leads us away from our behavioral change target. Really making the impact of AMR salient could be a very important intervention in and of itself to test. But even bigger picture could be looking at the low-hanging fruit where some of the best practices we know from the scientific literature we must be promoting are just too hard for stakeholders to do. A lot of times we spend time and energy focusing on trying to persuade, convince, communicate, educate, which are all super important, but sometimes that default approach of our own blinds us from the opportunity of doing a really clear scoping of the problem. That one of the best benefits of doing a behavioral diagnostic exercise is to find out where behavioral science will add absolutely zero value. I've seen proposals for WASH where we want to do a huge awareness campaign around washing hands, when there is no running water that reaches that village. So I don't want to be, don't intend to leave a facile remark, but just to say, in addition, exploring these contextual barriers is something we just don't do enough. And as Professor Sirota mentioned, we need rapidly to ramp up this research. And as I mentioned, we can involve the stakeholders themselves in being agents of said research together. So I think, and your idea is very valid. The most relevant and salient aspect is often something that can really drive change. So we need to look for those opportunities.
Great, thank you. Padmini?
Thank you. Thank you to the speakers for a really interesting and provocative session. I have a question. I think I'll propose it to Dr. Kars, but maybe others would like to answer as well. We've talked a little bit about prizes and economic incentives, but my question is actually really around legal frameworks. So, in the United States, we've been talking a little bit about healthcare-associated infections. In the United States, I think significant changes in reporting and also reductions in incidence of healthcare-associated infections happened when reimbursement through CMS actually changed, and it was this sort of a legal framework or reimbursement framework that really propelled a lot of change and propelled resources coming in. And I was heartened to see Africa CDC in August of 2023 has also put forward a legal framework for infection prevention and control, because there's a lot that can be done in IPC, but it needs the resources to actually affect change. So how do you see that interplay between legal frameworks or regulatory frameworks and behavior change, both in the facility and maybe even broader into the community? I know, Dr. Kars, you've spoken about the Swedish experience of antibiotic use and in the community, but how is that also tied to legal or regulatory frameworks?
Thank you. This is really, really important question. I mean, we need to monitor. We need to have monitoring for accountability. We need to measure. We need to benchmark what's going on. And I think in Sweden, where IPC was underdeveloped for many years, and the MRSA outbreaks that we had in hospitals were kicking off a lot of activities, and then came something called the Patient Safety Initiative from the government, which led to bonuses or money flowing into the local governments if they can provide evidence that they have been doing that and that and that. And I think those sort of, you can have carrots and sticks, but maybe carrots is better in this case. You provide resources, infrastructure, even funding in monetary terms. It's of course much more problematic in the low and middle income countries, but we really need to measure and monitor openly to be able to transform the system in the way we need. And prevention is such a key factor here. Again, the global players, the rich countries must come in place here. There is no money today available, very little. I mean, if you compare the global fund for HIV, tuberculosis, and malaria, it's huge in comparison to the small multi-partner trust fund that exists for AMR. It's widely different, and this needs to change. Otherwise, we will all fail, I think. But coming back to your question, I think it's absolutely needed to have legal frameworks, strong frameworks, and monitoring them.
Great, thanks. I want to move along through our questions just to make sure we get all of them. Jenny?
Thanks, and thank you to our excellent speakers. I certainly learned a lot. It's certainly been said that those who cannot affect change can't change anything. As a parent, I know this is true. But as many of you highlight in your talks, AMR moves at an incredibly fast pace and really waits for no one. But as we in our spheres know, any sort of education and change can really is iterative once, first of all, but it also can be incremental and very time intensive and resource intensive. That said, if there were just a few kind of wish list items of things that we need to take action on right now when it comes to this work, what would you say those would be?
I'm so sorry, Jenny. I missed the end of the question. I got cut off. Oh, sorry, Miroslav, you were going to go ahead.
No,
Apologies.
go ahead. Go ahead.
No, I don't. I just wanted to know the question. I apologize.
The question.
Yeah.
Go ahead.
So if I understood the question, then the question is what kind of research issues should have the priority because AMR is moving in a fast way. Did I understand it correctly?
Yep, that's right.
All right. So I think there are two things to establish here. One is, as we have noticed, I don't think we have the critical mass of behavioral scientists invested in this area. I think we need to have more people invested in this area. And that's why we were also exploring the different ways how we can engage people more with this, because we can have a list of research issues, but we have limited capacity to solve them as behavioral scientists. And therefore, even we are not going through the list, right? We're not keeping up with the pace of the pandemic as it's progressing. And that's why we also created a network. That's why we want to facilitate exchanges. That's why also we want to engage more social and behavioral scientists that are not aware of this issue. And the second thing is, I think we lack a deep understanding of what kind of research issue should be addressed. I think this should be addressed as a research problem in itself. So we're currently trying to conduct a Delphi study where we're trying to engage different stakeholders from different countries, where we would actually be able to form this kind of agenda of the behaviors and research problems that need to be tackled and then sort them by the priority. So I think people can have different opinions about what is the most important issue to solve, but I think it needs to be solved by including as many stakeholders and experts in the field to understand what kind of behaviors in which countries need to be tackled.
I want to move on to Michael for your question.
Thanks. And this is actually more of a comment, and I mentioned it at our last meeting, but it's actually upon us now. But CDC is going to have a convening with the CDC Foundation and other organizations, including WHO and Wellcome Trust, next week. And we're going to be talking about these very issues about how can we raise awareness, how can we do this more collectively, how can we track that and monitor it. Certainly happy to share some updates of that after the convening. The goal is really to have further conversation about it, and I really appreciate PACCARB for having this session, and I really appreciate the comments from everybody. I think this is one of the key areas that is really underappreciated, and really the scale of the challenges that we face here is on par with some of the scientific challenges that we face in many of the other areas, but I think it's very underappreciated about how we do this and how we do it effectively. Because we were practically talking about how do we motivate action to potentially everyone on the globe, right? When we're talking about this, we're talking about the general public, we're talking about policymakers, we're talking about people who are working in these industries, and patients, and that's all of us. So how do we practically do that, and how do we do it in a way that is tailored and makes sense and provides functional help for everyone? And that's a big problem. So I don't think we can underestimate it, and I think we should continue to talk about it and wrestle with it.
Great. And I'm going to round out the discussion with my own question. I was interested in both something that Professor Sirota said, and you just said right now in terms of a priority topic. And in Mr. Price's talk, you had this statement, make AMR social science, quote, more normal. So I'm a sociologist who studies AMR, and I do believe that it's important to integrate more behavioral science into all of this work and social science. But Professor Sirota, do you have any specific ideas of ways to engage more social scientists and behavioral scientists in this work?
Yeah, as I said, building awareness of the issue of AMR, like building AMR into curriculum of social behavioral scientists, so that the students that are being educated within the master and PhD programs can understand and undertake this as into their research agenda. Then building very clear research agenda of what kind of behaviors and behavior change would matter in this specific context, right? What are actually the issues that we don't understand that needs to be tackled? Perhaps there are issues that we don't understand, but changing the behavior will have a minimal impact. So I think we need to always trying to understand it in a broader context. And I don't think that we have that understanding at the global level. You know, what are the reservoirs and pathways and so on that are the most influential? And I know that people are working on trying to establish how big a problem is, you know, waste management, and how the behavior contributes to this, and so on and so forth. But then once we know these things, then I think the bigger engagement, I think there is an intrinsic motivation of people to contribute with their science towards you know, global good. And I guess a lot of us decided to do this research because we understood the importance of this issue for the global health and the global health of our children, and you know, and all this stuff. So, but of course, extrinsic motivation is also important. So we have, when we analyze the, for example, contribution to the global health challenges in the prestigious journal in Nature Human Behavior, that is the prestigious journal for social and behavioral scientists, there were basically 2 commentary editorial papers published on AMR through the history of the journal, whereas hundreds and hundreds of COVID studies, right, or COVID relevant studies. So we can see the imbalance, right, that people are not producing, but then the editors are not thinking this is an important topic. So so I think extrinsic motivation, providing funding, specific calls that try to engage funding. I know that the ESRC, Economic Social Research Council, a couple of years ago had a specific call to engage the social and behavioral sciences into AMR. That's the kind of thing that raise awareness that this is an issue, that this is an actually attractive area of research to pursue. I mean, there's nothing since then, right? But that's the general gist. I don't know, maybe Courtney and
Yeah. Great. No, thank you so much. And I do want to keep us on time. Thank you so much for the wonderful presentations, the thoughtful discussion. I know we learned a great deal.
Produced by the U.S. Department of Health and Human Services.